Yeah, so PACE is actually part of an umbrella of 3 studies. PACE A, which is a randomised study comparing stereotactic radiotherapy and radical prostatectomy. PACE B, which is a study we presented, is a randomised study comparing SBRT with conventional or moderately hypofractionated radiotherapy. And PACE C is a study still to be launched, which is very similar to PACE B, but in a higher risk group population, and the difference being that all the patients will receive androgen deprivation in addition to radiotherapy, which they didn't in PACE B. So the main aims of PACE B were to determine whether SBRT, or profoundly hypofractionated radiotherapy, is non-inferior to conventional or moderately hypofractionated radiotherapy. We're quite a way off knowing the end outcomes of the study, but we had planned to do an analysis of acute toxicity when we'd got all the patients past 3 months of follow-up. And that's the data that we presented yesterday. Well, essentially it's the dose. So historically in radiotherapy we've always used small doses per day over a protracted period of time, but we've got good data in prostate cancer that using a moderately hypofractionated, so a slightly larger dose going from 2 gray to 3 gray, was non-inferior, and that was the result of the CHIP study. So SBRT is essentially pushing that envelope and going to a much larger dose. So instead of 3 gray per day, we're using 7.5 gray a day. And the concept is that with modern techniques, with new radiotherapy machines, you can deliver these very large doses more accurately and therefore safely. And the concept being that these large doses will be more effective than the smaller doses. So what we did is we measured toxicity at baseline using both the RTOG scale and the CTACE scale. But the study was actually powered on RTOG, and that's what we presented yesterday. So all the toxicity was measured at baseline. Then for patients having the conventional fractionation was measured 2 weekly whilst on treatment, and for SBRT at the end of radiotherapy, and then at 2 weeks, 4 weeks, 8 weeks, and 12 weeks following treatment for all patients. And what we showed is that, in fact, the toxicity throughout the study was lower than we expected. So we expected toxicity rates in the region of about 30% for GU and about 45%, for GI and about 45% for GU, and that's based on literature and also the previously conducted CHIP study. But actually we found significantly lower results in both the control arm and the experimental arm. And very importantly, we found no statistical difference between the conventionally fractionated radiotherapy and the stereotactic radiotherapy. So we think it's important because we were concerned that with these large doses per day, we may see acute toxicity being worse, but that's not been borne out. If anything, it looked slightly better, but that wasn't statistically significant, but it definitely wasn't worse. Well, it's too early to make recommendations because we need to wait for the end outcomes of the study. So, I don't feel that people should take our results and say, well, we now should call this a standard of care treatment. It's encouraging, it supports the data that's out there already, but until we get the results in terms of the cancer outcomes and the late toxicity, I think this should still be considered an option but not a standard of care treatment. So it's not possible for me to say exactly because it's an event rate driven and I don't get to see that data, the independent data monitoring committee do, but I would estimate in probably 2.5 to 3 years.